Define access cavity. What are the principles to be followed during access cavity preparation? Describe access cavity preparation for upper central incisor. If such a question comes for your exam, first you have to give a flow chart. That is the contents. And the contents should include, first we have to give an introduction, definition for access cavity, goals of access cavity preparation, the principles or guidelines of access cavity preparation, the pre-operative considerations which include armamentarium for access cavity preparation, the assessment of occlusal tooth anatomy, complicating factors, radiographic assessment, then clinical considerations. Then you can explain the access cavity preparation for the maxillary central incisor. And for that, you have to also mention the average tooth length, the morphology of the pulp chamber, the clinical significance, and then the shape of the access cavity and the procedure by which you are doing it. Starting with the introduction, the endodontic treatment starts with an ideal access cavity preparation, and further steps of root canal treatment are also based on its accuracy and correctness. You can draw a pyramid of endodontic treatment. The base of the pyramid will be access cavity preparation, then biomechanical preparation, and the apex of the pyramid will be obturation. An ideal coronal axis forms the foundation of pyramid of endodontic treatment. Then this is the definition for access cavity preparation. It is defined as an endodontic coronal preparation which enables unobstructed access to the canal orifices, a straight line access to apical foramen, complete control over instrumentation, and accommodates obturation technique. Then the goals of access cavity preparation: removal of all caries tooth structure, conservation of sound tooth structure, complete deroofing of the pulp chamber, removal of coronal pulp tissue, both vital and necrotic, location of all root canal orifices, and a straight line access to the root canal. Then moving on to the principles or guidelines of access cavity preparation. First, starting with pre-operative considerations. The armamentarium required for access cavity preparation are front surface mouth mirrors for better visualization, air rotor and slow speed rotary handpieces. Then the burrs, the different types of burrs can be used, starting with the round carbide burrs, number 2, number 4, and number 6, for removal of caries and defining the external outline shape. Then diamond burrs with round cutting ends for axial wall extensions, and Fisher carbide burrs and diamond burrs with safety tips. This diamond burrs with safety tips can be used for refining the external walls. The advantage is that you can refine the walls without causing an increase in the depth, as the end is non-cutting, or as the burr is safe-ended or non-cutting tip. You can just refine or laterally extend the access cavity walls without causing an increase in the depth of the cavity. That's the advantage of burrs with safety tips. Then round diamond burrs for entry into teeth with porcelain or metallic restorations. Then for calcified teeth, you can use extended long shank burrs such as Muller burrs and LN burrs. LN stands for long neck. Then the endodontic spoon excavators, then endodontic explorers such as BG16, CK17, etc. Then the additional aids are magnification and illumination aids such as loops, microscopes, etc. Then ultrasonic tips, you have to just mention some of the names. That is StarTex ultrasonic tips 1, 2, 3, and 5 for access refinement. Then micro openers and micro debriders. Then assessment of occlusal tooth anatomy. An unusual root canal anatomy is suspected when there is presence of an additional cusp or abnormality in the size and shape of the tooth. In such cases, there will be a slight deviation from the normal conventional shape and size of the pulpal morphology. And the major principle of endodontic access cavity outline form is that the internal anatomy of the tooth or the pulp dictates the external outline form. And this is accomplished by extending the preparation from inside of the tooth to outside surface, that is, working from inside to outside. Then the complicating factors are rotated or malpositioned teeth, tipping or mesial tilting, gross decay, teeth with full coverage restorations, abutment teeth of fixed prosthesis, and teeth with extensive calcifications. These are the factors which complicate the access cavity preparation. That is, apart from the conventional methods, we have to modify the preparation methods in these situations. Then pre-operative radiographic assessment is another important step. That is, we can pre-operatively assess the tooth before starting the procedure. From the preoperative radiograph, we can assess the degree of mesiodistal tilt of the tooth, the size and shape of the pulp chamber, the thickness of the roof of the pulp chamber. Then presence of pulp stones can be appreciated. Variations in the number of canals, that is, if there is an extra canal or the degree of curvature of the canals, and also if there is any changes in the furcation of perioradicular region. Then moving on to the clinical considerations. Complete removal of carious tooth structure and other restorative material. At the access opening stage itself, we have to remove the entire carious tooth structure before proceeding on to biomechanical preparation. And this would invariably lead into the pulp chamber. That is, at the first appointment itself, during the access cavity preparation itself, we have to remove the complete carious tooth structure. Then complete de-roofing and removal of dentinal shoulders. This help in achieving a straight line access and improve the clinical access to the root canals. And this is accomplished by using a round burr and working from inside out. Then dentinal shoulders are to be removed. They are not an anatomical entity by itself. They are just overhangings of enamel and dentin while doing the access cavity preparation. And the mandibular anteriors, lingual shoulder have to be removed. Maxillary anteriors, palatal shoulder, premolars, mesial and distal shoulders, maxillary molars, buccal and mesial shoulders, and mandibular molars, mesial and distal shoulders. And evaluation of the cemento-enamel junction. Krasner and Ranko have proposed 9 laws for locating the canal orifices, and they propose that cemento-enamel junction for CEJ is the most important anatomic landmark for determining the location of pulp chambers and root canal orifices. And these are the 9 laws. Law of centrality, law of concentricity, law of the cemento-enamel junction, law of symmetry 1, law of symmetry 2, law of color change, law of orifices location 1, 2, and 3. Law of centrality states that the floor of the pulp chamber is always located in the center of the tooth at the level of CEJ. Then law of concentricity, the walls of the pulp chamber are always concentric to the external surface of the tooth at the level of CEJ. And law of CEJ, the distance from the external surface of the clinical crown to the wall of the pulp chamber is the same throughout the circumference of the tooth at the level of CEJ. And CEJ is the most consistent, repeatable landmark for locating the position of the pulp chamber. Then law of symmetry 1, except for maxillary molars, the orifices of the canals are equidistant from a line drawn in a mesiodistal direction through the pulp chamber floor. And law of symmetry 2, except for maxillary molars, the orifices of the canals lie on a line perpendicular to a line drawn in a mesiodistal direction across the center of the floor of the pulp chamber. And law of color change, the color of the pulp chamber floor is always darker than the walls. And law of orifices location 1, the orifices of the root canals are always located at the junction of the walls and the floor. And orifice location 2, the orifices of the root canals are located at angles in the floor wall junction. And third one, the orifices of the root canals are located at the terminus of the root developmental fusion lines. Then different areas will have different colors. Enamel will be whitish in appearance, dentin much more yellow, floor of the pulp chamber gray, root canal orifices will be seen as dark gray or black areas, and pulp stones will be seen as pearly white or dark yellow. Then champagne bubble test, this is a test which we usually do when we doubt or suspect an extra canal, such as in maxillary first molar, if you doubt there is an extra mesiobuccal canal or MB2, and in case of mandibular molars, there will be an extra canal like middle mesial canals. In such cases, after access opening, we have to flood the pulp chamber with sodium hypochlorite irrigant, and the initial pulp tissue and the bleeding will be, and all those debris will be get removed, and there will be a clear area of the pulpal floor. And when we have to explore, or when you have to excavate or extend the cavity preparation to obtain an additional canal, we can use this champagne bubble test. That is, the sodium hypochlorite irrigant is allowed to remain within the pulp chamber following access cavity preparation. The appearance of bubbles frothing out from a point in the floor of the pulp chamber is indicative of the presence of a root canal orifice. That is, if we doubt an extra root canal orifice after access cavity preparation, the sodium hypochlorite irrigant is allowed to remain within the access cavity. And if there is an additional canal orifice, bubbles will be coming from that orifice point. And in that way, we can detect an extra canal orifice. And this is known as champagne bubble test. Then significance of straight line access. A straight line access is needed to allow complete freedom of endodontic instruments in the coronal cavity and direct access to the apical canal. And this is especially helpful in severely curved roots. And the cavity walls are generally reduced with burrs or long thin diamond points and with endodontic files, gates, Glidden drills, or orifice openers. Then mouse hole effect. If the lateral wall of the cavity has not been sufficiently extended and the pulpal horn portion of the orifice still remains in the wall, the orifice will have the appearance of a tiny mouse hole. This occurs due to the extension of the canal orifice into the axial wall. And by extending the lateral wall of the cavity as removing all intervening dentin from the orifice, the mouse hole in the wall will be eliminated and the orifice will appear completely on the floor. This can be asked for your viva also. What is mouse hole effect? Then moving on to the access cavity preparation for maxillary central incisor. Before starting with the procedure, we have to just give an introduction about the anatomy of the tooth. That is, the average tooth length is 22.8 millimeters, and the pulp chamber is usually located in the center of the crown, equidistant from the dentinal walls, and it is broad mesiodistally with its broadest part incisally aligned. There is usually one root with one root canal, and the clinical significance: 75% cases the roots are straight, 17% the roots may curve labially or palatally, and in 24% cases there will be lateral canals in apical third portion. And the most common iatrogenic error committed during access cavity preparation for maxillary central incisors is that labial perforations. Then the access cavity shape for a maxillary central incisor is slightly triangular, with the base of the triangle towards the incisal edge and the apex of the triangle towards the cingulum. The enamel is first penetrated in the center of the lingual surface at an angle perpendicular to it with a number 4 round burr in a high-speed contraangle handpiece. After penetration of the enamel, the burr is directed along the long axis of the tooth until the pulp chamber is reached. And the moment you reach the pulp chamber, you will feel a drop. That is, a drop of the burr into the pulp chamber may be felt if the pulp chamber is comparatively larger in shape or larger in size. And overhanging enamel and dentin of the palatal roof of the pulp chamber are removed with a number 4 round burr. A Gates Glidden drill or any orifice enlarger can be used to remove the palatal shoulder by working from inside to outside with light strokes. And direct access can be verified by placing the straight end of the endodontic explorer into the canal orifice, and the explorer should follow the path of the canal without impedance from the walls of the surrounding access preparation. And this is the diagrammatic representation. First, you have to keep the burr perpendicular to penetrate the enamel. And once the enamel is penetrated, you can keep the burr parallel to the long axis of the tooth to cut the dentin. And after the dentin is removed, the moment you reach the pulp chamber, you will feel a drop into the pulp chamber. And then using Gates Glidden number 4 or any other orifice enlarger, you can remove the palatal or lingual shoulder. And a straight line access is then obtained, and that can be verified by using an endodontic explorer. And by inserting an explorer, it should insert smoothly. It should move into the chamber smoothly without any hindrance from the surrounding walls. In this way, you have to frame the answer. Suppose if an essay question comes, in this way, you have to frame the answer. First, you have to give a flow chart which include introduction, definition, the goals of access cavity preparation, then the principles or guidelines of access cavity preparation, which include the preoperative considerations and clinical considerations. And then finally, you can start with the maxillary central incisor access cavity preparation. Just give an introduction about the morphology, the length, the size and shape of the pulp chamber, and finally, how you do the access cavity preparation, the angulation with which burr you are starting the preparation and all. So finally, you have to draw this diagram also. In this way, you have to frame the answer.